Yes, ladies and gentlemen, we always need a leader, a guide who can take our hand and show us through. We as doctors are lucky to be commanded and headed by the paragon of this profession, now a dedicated representative of physicians. His knowledge compounds with his compassion and his fearless character to make an unmatched leader. Ladies and gentlemen, please put your hands together for President Pakistan Society of Internal Medicine, Professor Dr. Javed Akram.
ठीक है Bismillahirrahmanirrahim and Assalamu alaikum or Namaste to my dear brother Bikaram Saab. Namaste and Assalamu alaikum to everybody. Thank you. I'm humbled really to deliver my third presidential lecture. Whatever after Almighty Allah's blessing, I think it's because of all of you, each one of you in this hall. You have made the difference. The team at PSIM, the supporters of PSIM, like Captain Iqbal Saab, and of course, my very, very worthy teacher, Professor Isma Saab. I learned so much from him, just like Rizwan said. Hazrat Ali said, जिसने एक लफ्ज़ पढ़ाया वो मेरा उस्ताद बन गया और मैं उसका गुलाम हो गया. इन्होंने तो हमें बहुत कुछ पढ़ाया. आज जिस भी अल्लाह ताला ने हमें मकाम दिया वो we owe it to our teachers in him, and we have learned so much from him. I don't think I have come across many selfless people like him. Another teacher of mine, Professor Shayar, just entered. May Allah bless him with long and very, very happy life. Again, I request him to come to the stage, sir. Sir, stage पे sir. हमें इज़्ज़त अफ़ज़ाई बख्शे sir. Thank you so much, sir, for coming from all the way from Lahore, just flown in. And Shayar Saab, believe me, I was his student and then house physician. मेरा house job cardiology में था सबसे पहला. शयार साहब उस वक़्त नए अमेरिका से आए थे, अभी भी यंग हैं. आपने देखा मास्क उतार भी देंगे तो यंग हैं, वैसे मास्क के साथ तो बिल्कुल ही यंग हैं. तो वो जो इनके राउंड्स होते थे, जो इनसे मैंने बहुत कुछ सीखा. लेकिन ऑनेस्टली एक मैंने देखा कि पेशेंट की साथ आई विश के एम्पैथी में ये फीचर करते. ऑनेस्टली the communication skills that he has and the confidence he gives. जब ये मरीज़ को देखते थे as a cardiologist, तो जो उसका हार्ट रेट 110 से 60 पे आ जाता था, 65 पे आ जाता था, because you know he would really so much the adrenaline was lowered, believe me, and I say it from the heart. So I have the liberty of choosing कि मैं जिस चीज़ पे भी बात करना चाहूँ internal medicine में because this is a presidential lecture, so I can do it. So I have no conflict of interest to declare in this talk, and I chose the theme. मैंने बहुत सोचा कि क्या theme होनी चाहिए. So I thought evidence based medicine. ये जो प्रोफेसर आफ्ताब मोहसिन है मेरा छोटा भाई, इसने बहुत काम किए हैं. आज जहाँ भी हैं इसकी साजिद, अज़ीज़ साहब, Tariq, Somi, of course, our kid sister, as we call it, and a whole team at PSIM has played, and our another small kid sister, Wafa or Bewafa, both in her. So there's so many people अपना बैठे हैं हमारे डायबिटीज़ के चेयर ज़मान शेख साहब, जिन्होंने अल्हम्दुलिल्लाह कश्मीर से हमारे प्रेसिडेंट आए हुए हैं, खालिद रिजवान ऑफ कोर्स, एंड दोनों खालिद, लाहौर के प्रेसिडेंट और कश्मीर के दोनों खालिद हैं, दोनों माशाल्लाह ज़बरदस्त हैं. और फिर अपना सपोर्ट कमिंग फ्रॉम ऑफ कोर्स शहबाज कुरैशी साहब, and then our friends of friends in Shaukat Javed Sahab, so many, and of course we have, he's my very treasured friend, like PSIM ke recently हुए शहजाद, Vice Chancellor from Islamabad, and of course supporters in the pharmaceutical industry, like so many, you know, कैप्टन साहब का मेरा और इनका ताल्लुक 40 साल से है और मुल्क के दुनिया के कई हिस्सों में है, एंड वी हैव वेरी वेरी फॉन्ड मेमोरीज ऑफ, एंड देन जो फार्मास्यूटिकल कंपनी से मुझे सपोर्ट मिली. आफ्ताब मोहसिन का मैं दो चीज़ों के बारे में ज़रूर कहूँगा, और ये अल्लाह ताला ने इनको बहुत सलाहियतें दी हैं, लेकिन जो एक सलाहियत दी है, ही कम्स अप विद ए ग्रेट abbreviations or ideas. Though ideas, believe me, it has come straight from him. एक तो ये evidence based medicine अपनाओ, this is his innovation, honestly. This is his patent, so you can get royalties, or if we do end up earning anything the way you spend. I'm sure PSIM will be the first society to be bankrupt if it wasn't for people like Captain Iqbal Sahab और हमारे जो दोस्त इंडस फार्मा और फार्मीवो एंड गेट्स एंड सो मैनी सपोर्टर्स. अल्लाह ताला इनको फरिश्ता बना के, एटको, ऑल्दो एटको का मुझे अभी चेक मिलना है, उन्होंने भी आपके क्लिनिक में, काशिफ भाई आपके क्लिनिक में अभी आपका लोगो लगा दिया है. सर अल्लाह वाला साहब को कहें कि अल्लाह के लिए भी करें, वो इट इज़ फॉर अल्लाह एंड बाय अल्लाह. थैंक यू सो मच. मगर काशिफ इज़ पार्ट ऑफ द फैमिली. थैंक यू सो मच. तो इन्होंने ये जो अपनाओ है एविडेंस बेस्ड, इनकी थीम थी और हमने वाकई ही उसको अपनाया और इंशाल्लाह अपनाते रहेंगे फॉर द सेक ऑफ द पेशेंट. एंड देन इन्होंने एक और ज़बरदस्त इनोवेशन की, वो भी इन्हीं का पेटेंट होना चाहिए, और वो है आपका क्लिनिक. हमें समझ नहीं लगती थी कि हमने फ्री क्लिनिक्स बनानी है पूरे पाकिस्तान में, ये ख्वाब है हमारा, और हमने अपने आप को नहीं देख के बना रहे हैं, हम अल्लाह को देख के बना रहे हैं, हम उसके लिए बना रहे हैं, उसको शराकतदार बना रहे हैं अपने बिज़नेस में, और हम एक्सपेक्ट करते हैं कि इंशाल्लाह उसने कभी भी किसी को मायूस नहीं किया, और वो हमें भी बहुत, अल्लाह ताला को जब शराकतदार बनाया तो फ़िक्र क्या, कौन चलाएगा, कैसे चलेगा. ख्वाब है कि एक जाल बने फ्री क्लिनिक्स का, जहाँ पे 5,000 रुपये लेने वाले डॉक्टर्स फ्री देखें, जहाँ पे दवायात भी फ्री हों, जहाँ पे टेस्ट भी फ्री हों, और अल्लाह ने वो कर दिया, एटलीस्ट इन वन ऑफ द क्लिनिक्स इन लाहौर, जो आपका क्लिनिक है. एंड थैंक यू फॉर द नेम अगेन गिवन बाय आफ्ताब मोहसिन. तो इसलिए जब आपकी नीयत अच्छी होती है तो मिलते जाते हैं. और हमारे सिंध के प्रेसिडेंट बैठे हैं अभी, कराम साहब, थैंक यू सो मच फॉर ऑलवेज. आई एम वेरी वेरी प्राउड रिसिपिएंट ऑफ दिस फेलोशिप. मेरे पास अल्हम्दुलिल्लाह काफ़ी फेलोशिप्स हैं, लेकिन आई एम वेरी प्राउड, पाकिस्तानी एक ही फेलोशिप है और है फेलो पाकिस्तान सोसाइटी ऑफ इंटरनल मेडिसिन. एंड आई कॉन्ग्रेचुलेट माई कोलीग्स हु वर अवॉर्डेड फेलोशिप टुडे through a very stringent process by Professor Aftab Mohsin. I'll talk about what is evidence-based medicine, and I'll try to formulate a clinical question and pose that question to you, that how will you bring in evidence-based approach in this, apply levels of evidence, the hierarchy of evidence to decision making in clinical process, including patient concerns. So what are the major evidence-based medicine databases? Search for evidence-based information using Ebm Hunting Tools, and then I'll conclude. This is the definition. It's a recent baby, evidence-based medicine. It only came to the attention in 1996 when the article was published by Sackett and his colleagues. Like just in 4 years, this definition was thrown away. Just in 4. It could survive only 4 years because it was heavily criticized. It was criticized because this was very difficult to implement, this type of evidence-based medicine. And also, the other very, very important thing was missing in this definition was patient concern. Patient was not in the paradigm of evidence-based medicine, and that is why it died down within 4 years and was replaced again by the same team, Sackett. And again, 2000, it was published that evidence-based medicine and this survived, this definition survives till today. This is the definition that we use, that it is the integration of best research evidence with clinical expertise and, of course, very importantly, patient values. It reflects a systemic approach to clinical problem solving. And you can see that on these patient values and expectations are very much there in this definition, apart from best external evidence and individual clinical expertise. So you combine these three and you do have, evidence-based medicine over there. So very important, what skills we need as clinicians to practice evidence-based medicine. These are the minimum skills that we all need. We need information mastery. You need to be mastering this skill of information, finding the best evidence for our everyday practice, having at our fingertips just-in-time information at the point of care for clinical decision making. So that's extremely important. Where and how can we do it? Usually web-based or personal digital assistance, usually a smartphone these days. Okay. So evaluate best expert-based information, including from colleagues, CME conferences like this one, presentation, reviews, and guidelines. Advanced EPM skills, evidence-based medicine skills, not everybody needs to know them, but obviously a small percentage of clinicians like Professor Azizur Rahman sitting there, they have these on fingertips as well. It's good to know them, that what's the way forward. Clinical appraisal and interpretation of research on therapies, diagnostic tests, and prognosis. They're very, very important. Clinical evaluation and interpretation of systemic reviews, they are right at the top. Systemic reviews, including meta-analysis, especially of randomized clinical trials. They are the tip of the iceberg, really. They are the best evidence source. Decision analysis, practice guidelines, pharmaceutical advertising, including pharmaceutical representatives. We do all learn from them because new drugs are coming in and they do come and brief us about these things. Then important thing is assigning levels of evidence to your own or other people's research findings. And then, of course, at the end, we need to have written communication of research findings for other colleagues and for the patients also in the simpler form. This is a problem. This is growth of medical literature from 1946 to 2019. You can see exponential number of new journal articles. You can see rocketing up and continue to rocket up. And what about the numbers of RCTs, randomized clinical trials? You can again see so much research occurring. Of course, COVID-19, more than 200,000 articles and preprints published till last December. So much database. Unfortunately, I'll say, I'm disappointed as a Pakistani, just like you, that we are no way, we are potentially the third largest population in the world. Of course, we are fourth now, but we will soon be third, unfortunately. But we are not on the landscape of research at all. China, a young country, is leading, and now US is following the clinical trial registries. So we all, I hope I am a lifelong learner. What was the old method that our teachers, Professor may Allah bless them, long life, Professor Shahyar Saab, Professor Mahmood Ali Malik Saab, Khwaja Sadiq Saab, old method, read a few journal articles per week. Reality, what is the reality? PSIM members, what they need to do? They need to read for 17 hours a day just to review reasonable and pertinent material. If you are an internist, you need 17 hours a day. So how can we do that? It's practically not possible. Even in a narrow specialty like psychiatry, you need 6 hours per week. And a family physician, they need about 1.5 hours per week still. So it's almost not practical. So how can we practically be a lifelong learner? From our day-to-day encounters. Reading the articles that happen to be on your desk, on your consulting room, but that doesn't help my patient that day. May not be applicable to that patient that I am seeing, but the article is there. So I will read it and forget about it because there is a limited memory. I won't be able to recall it. So the best help is finding evidence-based optimal care for my patients today and help them and help me to stay current in my field and be an efficient and effective lifelong learner. So I see a patient, I have the symptoms and I have signs, and then I retrospectively read about that. I search about that, and then it's likely that that experience will stay with me for a longer time than just reading a book or an article. EBM is, ladies and gentlemen, is learning by doing. Simple as that. So you have to be addicted to EBM, believe me, and you will have this mastery of EBM. EBM, you cannot be an EBM physician till you have an attitude of lifelong learner, because medicine is rapidly changing landscape. So practically, PICO, this is the Bible of EBM, the patient, of course, the most important. So we start with the patient, we start with a clinical problem or a question arises out of the care of the patient. We have a question coming out of this patient in a clinical scenario, and then the question, we construct a well-built question derived from that case, and then we select which resource we are going to use. Very, very important. Which resource you can't, there's so many resources that it confuses you. So you have to decide which resource you are good at, so you can't master all the resources. So a couple of resources choose and be master of that. Time efficient, at the point of care on your fingertips. So then the evaluation, appraise that evidence for its validity, closeness to the truth, very important. That how much you trust this evidence that is coming, you take out the bias out of it. And then the applicability in your clinical practice to that patient. And then, of course, you return to the patient, integrate the evidence with clinical expertise, patient's preferences and family preferences, and then apply it to your practice. That is what evidence-based medicine is. And very important to evaluate your performance, because ultimately, if the patient dies or the patient gets healed by the grace of Almighty Allah, because we are nobody to heal a patient, it's Almighty Allah who heals. He may use me or you. So you have to keep on evaluating, self-evaluating yourself from the patient feedback and the relatives feedback. मैं ज़रूर कोशिश करता हूँ कि जो मरीज़ मेरे हाथों में मरते हैं मैं उनके ज़रूर जाता हूँ जनाज़ों पे या कुल्लों पे या बाद में फातिहा करने, और मैंने ये इस चीज़ प्रोफेसर शहरियार साहब से सीखी। मेरे लिए ये बहुत इम्पॉर्टेंट होता है कि उसके कुल्लों पे या चले इसमें पे मेरे बारे में जब मैं जप्फी डालता हूँ उनको तो क्या कहा जा रहा है, डॉक्टर साहब तुसी ते पूरी कमाल करता, तुसी पूरा जोर लाता, लेकिन अल्लाह ने उन्होंने एनी लिखी सी या somehow something else sometimes. तो doesn't matter if I save or I lose a patient, वो तो अल्लाह ताला की एक एक सांस लिखा है. But important thing is what is the feedback for me. और मैं किसी को छुपाए रखूं कि जी मुझे गालियाँ पड़ रही थी, लेकिन अपने आप को तो मुझे पता है ना, मैं I have to re-evaluate कि where did I go wrong in communication or whatever. And we all need to learn it from Shariar Sahib. Honestly, I'm saying, he is the master of this. So PICO, as I told you, constructing a clinical question, patient, kaun hai, who, intervention, what intervention. Now intervention may be no intervention. That is still an intervention. Just observe. कुछ नहीं करना, ना टेस्ट कराना है, कोई ज़रूरत नहीं है. मिग्रेन का केस है, इसका क्या टेस्ट कराना है, रहने दो, ठीक है. You are confident that it's a case of cluster headaches or migraine. मगर that still is an intervention to me, ठीक है. Alternative comparison, कि क्या do nothing, that is still their choice, or do test, that is an intervention, or do a procedure, or write a medicine, that's still an intervention. And then finally the outcome. So patient, how do I describe a group of patients similar to this particular patient? Intervention, which treatment or test or other intervention compared to doing nothing, what treatment options or what interventions are there, or outcome kya hai, prognosis, okay, what is the patient oriented outcome, better prognosis or cure. Just an example for my younger colleagues here, 22 years Eid pe, abhi chand din hue, taru guzra hai. On the second day of Eid, 22 years male with vomiting. So intervention क्या होगी इसकी? ORS. Comparison क्या है? तो वो भी ना दूं, चलो डायमपेरिडोन की दे दूं, उल्टियाँ आ रही थी, ठीक है. तो outcome क्या होगी? Symptom free after 2 days. So just an example. Micro hematuria, intervention IVP, comparison maybe CT with contrast, outcome predictive accuracy. Okay. 70 years old gentleman with resolving right-sided weakness for few hours, intervention CT scan or do nothing. Outcome kya hai? Rates of CVA within 90 days. So that will be the outcome. Okay. Healthy adolescents, 19 years old boy with on routine blood pressure screening. चाहिए, नहीं चाहिए, no screening, evaluate only if problem occurs. Okay, outcome, target organ damage or need for intervention like renal artery stenosis or whatever. So, best answered EBM resources. Therapy question, in patients with migrainous headaches without auras, is sodium valproate more effective than propranolol for prophylaxis of headache? This is a therapy question that you are posed. Prognostic question, diabetic patients with foot ulcers, is the diagnosis of osteomyelitis with MRI as predictive of healing as an audible pulse on Doppler examination? Diagnostic question. In geriatric patients with suspected carotid stenosis, is duplex ultrasound as good as MRA, magnetic resonance angiography, in detecting significant carotid stenosis? So that is diagnosis. Harm question. अजीज साहब को मैंने कहा था मैं कॉफ़ी का नाम ज़रूर लूँगा, अभी ये मैं लिख रहा था. For pregnant patients, does the consumption of large amounts of coffee compared to non-coffee drinker increases the risk of spontaneous abortions? So, these are just few very primitive, very important, like these pyramids, okay, pharaohs. Here you have meta-analysis which contains at least 7 randomized clinical trials. Very important. They are the highest Cochrane reviews, whatever. These are the. Okay, what about cohort studies? They are still good evidence. But what about over there? Reviews, open label trials, and editorials, opinions. But remember, these are still evidence. You can't just, they're not dustbin stuff. They are important stuff in many, many situations. So what we do is we give a level to the evidence, and this is Oxford rating. University of Oxford came up with level 1, which is systemic reviews, meta-analysis of RCTs, randomized clinical trials, cohort studies, number 3, case control studies, case series, and then at the end, expert opinions. But they are all important, but of course you need to give them a hierarchy. The highest level, they further categorized strength of recommendations there, SOR, or level of evidence, A, B, and C. So 1A is the strongest evidence. I happen to be, reading the guidelines of American College of Cardiology, of which I am again a proud fellow. 1A evidence is strongest everywhere. Okay, you can blindly trust it. Then B is still, 1B is good, 1C is still good, then level 2, and then similarly. So what about forging tools? I am sure Aftab Mohsin will tell us what this word means, because शायद मेरे जो पीछे बच्चे बैठे हैं उनको ना पता हो. क्यों जी, पता है किसी को forging? Anybody knows what it means? Google कर लेंगे उतनी देर में. These are the tools. They are used by wild animals to gather their, in the forest, in the wilderness, to gather their feed. Hunt tools that are used, and ये हम evidence based medicine में बहुत use करते हैं ये लफ्ज़, forging tools. Okay, these are the people who use it. People heavyweights. अजीज़ुर रहमान साहब, तारिक बैठा है. ये जो heavy weights हैं, ये वो काम हमारे लिए करते हैं through forging tools. Very important. So, high quality forging tools employ a transparent process that systematically searches and reviews literature. Very important. Identify useful, valuable, quality research. Okay. Quality, you give quality to that research. Synthesizes into bottom line recommendation. Poem हम कहते हैं, not disease oriented outcomes, but patient oriented outcomes. Very important. We are treating the patients here, we are not treating the disease. That's important. Assign level of evidence 1A se leke, go down that ladder, and how to apply that recommendations. Very important. Here, this pyramid tells us everything. On the top of the pyramid, the strongest evidence coming from Cochrane reviews, systematic reviews, especially meta-analysis of randomized clinical trials, and then systematic reviews plus other cohort studies consisting of cohort studies, then evidence guidelines, then evidence summaries, RCTs, cohort control studies, clinical research critiques, other reviews of the literature, case report, case series, practical guidelines, clinical reference, texts like editorials, things like that. Cochrane, right there, clinical evidence, there. मैंने यॉर्क में क्योंकि काम किया है, यॉर्क यूनिवर्सिटी ने ये किया था, data and review evaluation tool, this is a good tool. Then journal clubs, very important. Unfortunately, Pakistan में नहीं है journal clubs, very, very important. Info, patient-oriented evidence that matters, poems, e-poems and poems, info poems. United States Preventive Task Force over there, bringing in, and of course, National Guideline Clearinghouse. These are just few examples, Cochrane collaborations, how, किस तरीके से apnea, sleep apnea की, ACP Journal Club, I'm a very proud member of American College of Physicians. You can see 140 internal medicine journals वो survey करते हैं, 140 top high impact journals जिनका impact factor high, highest validity, structured, ये उनकी website है, and लेकिन unfortunately महंगा काम है, about $80, lot of money per year. But they have a system के alerts आपको भेजते रहते हैं जो भी नई चीज़ आती है. So this is ACP Journal Club, and this is how it looks like. Just downloaded screenshots from there, and this is what I propose today. That I propose very, very strongly, and I hope my team will support me once again. They have never discouraged me, that we launch this PSIM Journal Club. And we select journals that we are going to include from Pakistan, especially Impact Factor Journal, Shaukat Javed Sahab ka, because we need to have local journal club. That is extremely important. And this is all, proposal. Obviously, Quran Pak नहीं लिखा गया, बदला जा सकता है, मेरे से बेहतर आप लोग समझ सकते हैं. Again, chaired by the most experienced physician, not just in this room, but in Pakistan, Professor Ijaz Vora, and co-chaired by who keeps us on our toes, and we keep on tolerating him all the time. मैंने कहा कि हमारा, लेकिन we love him for whatever he is doing. तो इनको co-chair किया जाए, अगर ये accept करेंगे तो मैं बहुत ही खुश हो जाऊँगा. And of course the editor is our own homegrown Professor Azizur Rahman, and co-editor is Tariq. So what I propose is that this should be based at our research center, which is the first floor of Aapka Clinic. Okay? And thank you to Scottman for supporting our research activities there. Broad-based representation होना बहुत ज़रूरी है इस journal club में. First Saturday of every month 2 से 3 बजे तक. Starting time भी और finishing time भी. 1 घंटा. Every fortnight we meet, and it should be open access. There should be no fee for this. All are most welcome to join in. I will definitely join in if I am allowed by the editorial committee. Proceedings are to be published quarterly, or at least twice a year. And we must dedicate a session to this PSIM Journal Club in every conference. So our chairman of committee is there, the academic Azizur Rahman Sahab, and I'm sure, I hope he agrees that a session is dedicated to PSIM Journal Club. We'll bring in the latest and the latest and the latest, and we'll categorize that evidence. Info poems, patient-oriented evidence that matters. That's another important for family physicians. I see many family physicians in this conference. It reviews systematic surveillance of 100 journals, recent research articles, patient concerns, morbidity, mortality, quality of life is addressed. Email updates are available, and very important. Info poems, just a screenshot for you. Does inhaled hypertonic saline improve clinical outcome in patients with cystic fibrosis or not? This is just an example. JAMA has this journal club. It's called JAMA Evidence. And here you can see BMJ Journal, Evidence-Based Medicine. Again, they have very good journal club. And my favorite is Up to Date. Up to Date is a very good resource. If you are not using it, please try it. This part is most important, graded recommendations. Here you can see. Obviously, there are other parts, but this part is very important. It reviews very, very quickly the papers which come in, and and for any journal to be reviewed or used as a EBM tool is very prestigious. And here you can see Up to Date, type 1 diabetes management guidelines. And then evidence-based medicine and practice is again an open access, no subscription required, but again a very good resource. Here is Journal of Evidence-Based Medicine. This is just a landscape of evidence-based medicine I'm giving you. This is guidelines.gov from USA. Okay, it is a multiple guideline clearinghouse, and you can get at least 1,600 guidelines on this resource, and this is totally evidence-based and highly referenced if you happen to visit this. So what about Ebm Hunting Tools? Very important to understand this also, that it's bottoms up, not top down approach. First, when you are searching for evidence, what do? You have to drill down as low as possible. Okay, you have to have the drill going right on the bottom base of the pyramid with Medline or Up to Date and things. And then if you don't, whatever you find about this patient at the point of clinical care, then you keep on refining it, and then you move your way up, and then you go on to the Cochrane reviews or clinical evidence, and look at the randomized clinical trials. So what are EBM hunting tools at the end? A high quality hunting tool will employ a transparent process that searches multiple evidence-based medicine databases, several fogging tools, as I told you, organizes results to make them easy to find, provides level of evidence for you. This is extremely important. Here is the level of evidence, 1A to 5C, you can see. Again, if you look at Cochrane reviews and systematic reviews and then meta-analysis and come down the clinical, here are the fogging tools that you can use, the hunting tools from this. And again, you can see the there from York University, EBM practice, ACP Journal Club being referred to, patient oriented evidence that matters, United States Preventive Task Force, National Guideline Wearing House, and textbooks. So you start drilling from below up and keep on refining your research. It's not the other way. This is again, PEPID is a very important resource. Anybody knows what PEPID stands for? It's a difficult word, difficult question, I can understand. Portable Emergency Physician Information Database. Okay, this integrates everything for you for the knowledge base at the point of care. So, ladies and gentlemen, I conclude this very, very humble attempt to define this vast sea of evidence-based medicine. EBM minimizes the error and optimizes the quality of patient care. Very important. reduces the cost of treatment, cost in the form of life and death and money, provides all the groups involved in providing the health care with a rigorous and acceptable framework for making complex clinical decisions, enables professionals to be confident in their decisions and to communicate them effectively to fellow colleagues and patients. Very important that the patient perspective must not be left behind. PSIM, I'm proud to say, stands for the implementation of EBM not just in this Pakistan, but all over the world. Wherever we go, we will take the slogan with us that we believe in evidence-based intervention, evidence-based medicine, और ये हम अपनाया भी है और अपनाए रखेंगे और कोशिश करेंगे कि सब अपनाएं. So today is the birthday of, I hope it's my proposal that let today be the birthday of PSIM Journal Club. So we at PSIM pledge to launch a robust EBM database, inshallah. Ameen. I thank you all for practicing evidence-based medicine. Thank you so much.